All right. Welcome, one and all. Okay, welcome, one and all, to an exciting new web series and season one of The Rising Star in Ophthalmology. I take a lot of pride and humility in introducing this web series with my co moderator, Jennifer Lowe, whose undying efforts in the field of ophthalmology is unparalleled. And she's worked tirelessly with me to create this first ever platform, which has been born online and going live, world streaming global. And we've put together this young Turks of new ophthalmologists on the podium, which is where we believe they belong. All this amidst a plethora of celebrated, experienced, and ever so wow talented celebrity panelists, whom I must thank personally first. And one of the people I must thank, and probably the most favorite person in the world for me, is who needs no introduction, Bill Trattler. His undying smile on his face and his amazing leadership comes bursting out whenever he sees a young Turk around him. And all of us here knows that he is one person who really loves to get the young John up and running. I know he did it to me, so I have to have him speak about these web series and what it means to him. So, Bill, can you give us what Rising Star is from your words?
Thank you so much, Ashwin, and welcome everyone. It's a really exciting time, and obviously things have changed quite dramatically over the last 6 months, where we're usually so used to being together, one-on-one together in big groups at meetings, but now we're not together, but it's just a little more difficult. So I love being able to meet new doctors, get them learn from them. All the young doctors have so much to share, but they don't always get a podium or a platform to share their wisdom, their ideas, and their thoughts and new suggestions. So we thought that Rising Stars in Ophthalmology would be a great platform for fantastic young ophthalmologists to be available to share their ideas, share new thoughts. And I thought that it would be a great series, and that's why I got together with Ashwin and Jennifer, and we thought we'd build the series. And of course, we're really excited about this first episode. We have 9 episodes in the series, and we have an incredible speaker, a rising star, and I think that person will be introduced by Dr. Lowe.
Perfect. Thank you, Bill. So before I happily hand over to Jennifer, I just wanted to tell all the viewers what we have in store for us today. So we have a young Turk talking about new technology and new techniques and innovative techniques in cataract surgery. I thought that would be the best start for this web series, and I'm going to hand it over to Jennifer to actually present the speakers and the celebrity panelists.
Thank you so much, Ashwin, and to everyone who's participating. I wanted to first introduce our celebrity panelists before I introduce our amazing rising star. So we have from California, the famous Dr. Sherry Rowan, who's living the dream in Cali. Former president of Cedars Aspen. Next up, we have Dr. Gary Wirtz from Kentucky, who's not only an amazing person, but a self-described surgical cutter, and here to share his wisdom with us. And then last but not least, we have the amazing Vance Thompson, who has inspired all of us with his kindness, his intelligence, and also he is a professional vintner. So he's overwhelmed us with his style. So now that we've introduced our celebrities, I wanted to also introduce our first rising star, and you're in for a treat. He has an amazing talk today. Our rising star for episode 1 of season 1 is Dr. Christos Ifantidis, and I have a PowerPoint presentation I'd like to share with you. So congratulations, Christos. You are our first award winner for this new series. Christos hails from the University of Florida. He went to undergrad there and graduated summa cum laude. He actually, before becoming a doctor, received his MBA from the University of Florida Business School, and then also received his medical degree in Florida. He then went on to complete his residency training in New York City at Mount Sinai, and then completed a fellowship at Wills Eye Hospital in not only anterior segment, but in academic global ophthalmology, where he's traveled the world. He settled down in Colorado to become an assistant professor and director of ophthalmic global outreach. And when he's not doing all of those activities and can catch his breath, he's actually in his spare time, which I'm sure he doesn't have much of. He's apparently a professional ATV rider and can not only jump with the ATV, but he does it in style wearing a suit. Him and his fiance get to travel the world, and he obviously has an adorable little dog. So I am honored to introduce to you Dr. Ephantides, and I cannot wait to hear his presentation. Thank you.
Thank you, Jen. As soon as we finish these few words from the organizers, we're just going to start with Christos.
Thank you so much for that very kind introduction, Jen, and Ashvin and Bill. Thank you for helping put this together. It was a monumental task, and thanks again to all of our celebrity panelists for spending their time with me this evening, this morning, this afternoon, wherever you are in the world. My talk today is going to be on new tech and new techniques in cataract surgery. My only relevant financial disclosure for this talk is Centricity Vision, who are the makers of the Zepto Precision Pulse Capsulotomy System. Also on the slide are just some of the many places I've been fortunate to work in throughout my career. And for any colleagues that are tuning in from around these sites, a big virtual hug and thank you for your support. And a special shout out to my OR team in Denver, Colorado, who I get to work with every week on these wild cases, and without you, none of this work would be possible. And so today, there's a lot of different technology that we could talk about, from IOL technology like the light adjustable lenses, pinhole IOLs that'll hopefully be coming to the US soon, trifocal IOLs that just hit the US market like the PanOptics, fragmentation technology for cataract surgery like the MyLoop or femtosecond laser-assisted cataract surgery, drug delivery platforms like the Extensa, which is a punctal plug that eludes steroid perioperatively for cataract surgery, and DexaQ, which is given intracamerally, both negating the need for drops post-operatively. And then finally, capsulotomy technology like the Veris ring, which is a ring that's placed on the anterior capsule of the cataract and helps guide a manual rhexis around. This was actually developed by a colleague of mine, Dr. Malika Hook, here at the University of Colorado. Of course, Flax can also create a capsulotomy, and then the Zepto Precision Pulse Capsulotomy System, which I'm actually going to be focusing on as my technology since we don't have too much time together. And so when the sun is shining on a perfect OR day, you can expect smooth surgeries and excellent post-op outcomes. However, everybody has their rainy days, and it's not so perfect with unexpected vitrectomies and a dropped nucleus. And so my first question to the panel, to tag team here, is what are the top 5 risk factors that you could think of for a dropped nucleus? So as a team, maybe you can throw out some answers as to what you think are the biggest risk factors for a dropped nucleus.
Well, I would start by saying if someone has had a lot of intravitreal injections, I feel like discontinuity in the posterior capsule before you start, that's a setup for a potential drop nucleus. So maybe I took the easy one, but that's something I always look for.
Great.
How about prior trauma?
It's a great suggestion too. Dr. Vance Thompson, do you have any input on that?
Any reason for extremely loose zonules, but I think another one is an unrecognized anterior capsular tear that extends posteriorly and the surgeon doesn't see it.
Great. Yeah, those are all great answers. Found a paper here in February of 2020 from JCRS. Great paper, big data, 1.7 million European cataract surgeries. This was the list of the 5 top complications. Vance, yours sort of speaks to the first one, right, with the Argentinian flag sign, especially with the anterior capsule wrapping around. But previous vitrectomy, pre-op poor vision, sort of signifying dense cataracts or opacifications, small pupil, and pseudoexfoliation, but white cataract was found to be the #1 cause in 1.7 million cataract surgeries. So that was a bit surprising to me, and I'm not sure if it surprises you or not, but I thought that was something to keep in mind as I go forward in my surgical career. And so the first case I want to present today is a white cataract. And this was a 27-year-old male, had a history of head trauma 2 months prior to presenting, fell off a sidewalk and hit his head. On presentation, he had hand motion vision, and this white cataract was under what looked to be a lot of pressure, no phacodenesis, and the B scan was normal. And so I'm going to pitch this first question to Dr. Gary Wirtz, and can you answer what would be your preferred capsulotomy technique for this white cataract under pressure?
Yeah, it really depends on the technology you have at your disposal. If you have a laser, I do think that flax can be useful here. It's common that you don't get a full capsule rhexis because as soon as the laser hits, it depressurizes, and it's common that you have some tags, but I have found that it's pretty easy to complete a laser capsulotomy and you don't run as much risk of a tear out. If you don't have access to that or a Zepto, which I've not used Zepto, but I've heard good things about that in this setting, I do think, possibly, doing everything you can to fight pressure, trying to make a very, very small anterior circular flap. I've seen Ashvin, I've operated with Ashvin before and have seen him basically go in with like just a 1 millimeter opening going into the cystotome. And that way you're really controlling the anterior pressure and vacuuming out or aspirating out some of the, some of the liquid that is no doubt in the bag. So, it's really about trying to control pressure if you're doing it manually. And sometimes you just, no matter what you do, it's going to be a nightmare.
Yeah, those are great options. Another technique, for me, one of the other options I use is high molecular weight viscoelastic like Helon 5, really pressurizing the anterior chamber, like you mentioned, trying to lower that pressure differential between the bag and the outside that causes the bag to pop like a balloon, right? And so one of the cases I'm going to present here, I presented at the ASCRS film contest. At that time, it was called Amazing Cataract Houdini. Now you see it, now you don't, and you'll see quite quickly why it's named that, but I'm just going to show a portion of that video here. And so at the beginning of the case, I make my normal wound here, 2.4 millimeters, and then you could see me checking the rod, engaging the nitinol ring here of the Zepto device. I'm going to use the Zepto in this case, and then I advance the rod, folding the silicone cup and ring of the device into a taco that then folds nicely and enters the eye through that main wound. This device actually can fit in 2.2 millimeters or bigger. And so I'm using a 2.4, but it will fit in something smaller than that. I retract the rod a bit, allowing that silicone cup to unfold along with the nitinol ring. Once it's in a nice circle, I place that Purkinje light image right in the middle of that silicone ring as best as I can, and start aspirating. It aspirates through there and applanates against the capsule, creating suction. So there's suction that applanates against the capsule. Once I feel like there's enough suction applied and vacuum is built up, I'll ask my assistant to press the energy button and apply the energy. And there you could see something definitely has changed. And if anybody's like me, at this moment in the surgery, I was wondering what the heck just happened. The cataract disappeared. I'm not sure if there's an anterior capsule or a posterior capsule. I wasn't sure whether the Zepto through the posterior capsule and the nucleus is resting on the vitreous. And so, Gary, I'll stick with you here. What do you think happened to the bag there in the cataract? Any guesses?
So you said this is a 27-year-old?
Yes.
I mean, this is a very random guess, but I mean, is it possible that it was completely liquefied? I mean, that would be a very weird thing. I think it's either liquefied and aspirated during as soon as you got suction and you created the capsulotomy, or the nucleus is sitting on the posterior pole. I think those are the two options, but I could be way off here. I really don't know what happened there.
No, those are great. So you've got the right thinking here. This is in slow motion here. As I apply the energy and that big capsulotomy is made, you could actually see contents going into the handpiece of the Zepto device. And so I wasn't sure what happened here. So I put viscoelastic in, just trying to look for any semblance of an anterior capsule or posterior capsule. And it turns out it looked like there was some anterior capsule there. So I used my IA to clean up some of that cortical wispy material. And sure enough, a capsulotomy was formed. A perfect capsulotomy was formed right on that Purkinje light image. Posterior capsule ended up being intact. And you're right, it had completely liquefied. So this was just a completely liquefied lens. I had never seen anything like this before. Usually there's something there. And I'm glad I'm not the only one who was surprised about that. But after putting the lens in, great centration. I thought I was in dire straits there, but it actually turns out that Zepto saved this from being a disastrous case and instead made it a very straightforward, easy case. 0.00 phaco energy, as you could see there. So great overlap of the lens, good centration. And so it made a very difficult case routine. And that was really favorable for this situation. And so just to briefly talk about Zepto here, you see the disposable handpiece here for those who are not familiar. This is the console that also sits in the OR and attaches to that handpiece and applies the aspiration, suction, and energy. This is the zoomed in image of the head of the Zepto device. This is what we would be seeing if it was facing the anterior capsule. You have a silicone cup, and that's the thing that creates that suction cup on the capsule. And then you have the nitinol ring inside of it. And so it creates the capsulotomy in this controlled environment. And so why is that important? So it creates a capsulotomy very quickly, 4 milliseconds using 12 micropulses of electrical energy. And I equate it to the old school science trick. If anybody's ever done this, you've got a balloon that's under pressure, just like a cataract that's under pressure, like we just had. And you had tape, you put tape on the balloon. And even if you go to try and pop the balloon with a needle, the tape keeps tension around that hole and prevents the balloon from popping and running out. Just like Zepto does, where you put that on the capsule and it can make a capsulotomy just like that hole without running out. And it prevents it from causing an Argentinian flag sign. And so in addition to using Zepto for routine cases, I think it's great for monofocal, multifocal toric because you can center that capsulotomy right on that visual axis using the Purkinje light image from when the patient's looking right at the light. I use it for a lot of different complex cases too, listed here. So I'm wondering, Gary, I know you mentioned that you don't have experience using this, but anybody else have experience using Zepto for complex cases?
I have experience using it for white cataracts and very dense lenses, loose zonules, and small pupils. Haven't really used it on what I would call a fibrotic capsule. I haven't purposely stayed away from it, but for those situations, I've used it and felt that it helped make them easier.
I have a question, panel, and Christos as well.
Sure.
And I think it's an audience question as well. So I know that you can use Zepto in these difficult cases, but just the mere fact that you may have a shallow chamber, how shallow can you use the Zepto? Because I do understand it could be a little bit bulky of a device, but how shallow do you go in terms of understanding where do you use it, not?
That's a great question. So a lot depends on the surgeon's comfort. So I would say when you're beginning, you do not do anything that's shallower than 2.1, 2.2. You really want to just have a normal anatomic chamber there. I've gotten away, especially with these pressurized lenses, for a little bit less than that. Especially if you use, and you should use dispersive viscoelastic for this because the cohesives can actually give a false signal to the machine saying that you've got good suction on the capsule. And that's just because the handpiece is occluded with cohesive viscoelastic. And so, and it will not fire the energy appropriately on the capsule. Nothing will basically happen. And so with dispersive, you can apply a good amount in there and to try and really pressurize, especially with the pressurized white cataract that could be bulging. and try and flatten that capsule out. And I found that that would allow me to have a little bit extra room. But really, when you're starting out, nothing less than 2.2, and then you can, you know, titrate to your danger level after that.
I would agree. And I also think I have more of an issue with deep chambers. And so I haven't had an issue with shallow chambers, and especially those intumescent cataracts. You get such a wonderful approximation of the suction cup to the lens. And what you really want is even approximation of that nitinol ring for 360 degrees. And it works so well with the intumescent lenses, and for shallow chambers, we really just want to be sure and protect the endothelium. And when you're putting in a device for the first time on a shallow chamber, sometimes you feel like you're rubbing against the lens too. And that's why when Christos says to put in a little extra viscoelastic or place your incision maybe a titch anterior, but you can work with that, and it works great in all these situations.
Yeah, those are all great points. And I've got a case actually of an intumescent cataract later, a very dark brunescent cataract. So moving on here, we're going to go to our second case. I know Van mentioned loose zonules here. So this is a 56-year-old male with loose zonules. About 20 years prior, he had gotten punched in the face, which seems to be a Denver Health special, which, you know, I take care of a lot of these patients with a lot of trauma. Vision 2200. This beautiful petaloid cataract can be seen here in the pictures on the right. Temporal loss of zonules. So I had the patient look to the right, and you could see that red reflex beyond the lens edge here. And so that's always a worrisome sign. Flattening of the capsule and signs of phacodemesis, both on exam and symptomatically. And so the only other thing is there's poor dilation here. So you can't see the entire area of interest since the center of the capsule here is shifted over, poor dilation. So I'm going to pitch this question to Dr. Sherry Rowan here. How would you approach this traumatic cataract, specifically expanding the iris, and then different methods for capsulotomy that you might consider? And would you use a CTR, and how would you secure the IOL?
I have the same case. A box or you know, loose zonules. I did a video called Rings, and Other Things. So there's a lot of things that you have to do here. One is you need good visualization. This is going to be really critical for this. Depending if you're talking, if I'm going to be able to feel like I'll either do a manual capsulotomy or I don't know. I don't have the experience with Zepto to know if you could put it in after, but I would use a Malyugin ring for my first entrance. I would get the pupil fully expanded so I could really have a good view. If I did not have a good view of the anterior capsule, I would then place Vision Blue in, so trypan blue, so I would know exactly where my capsule edges are, because I might need them later, and I'm sure I will, in fact, because he has no zonules over there. So now you have an iris dilator, you probably are going to have to put in capsule hooks, because you're going to have tension that's going to go to the opposite side. You might not even be able to rotate the ring. So you'll have a Malyugin, you'll have capsule hooks in to make sure that you have a fully expanded and safe capsule, and you'll be able to visualize it having used the trypan blue. Yes, as far as, so let's say now you have your exposure, you have everything intact for what you need to get started. You can make a capsulotomy. It looks like in this case, you should be able to make a very nice manual capsulotomy. And you do hydrodissection, try to get that lens rotated after you've put the capsule hooks in. And he's, how old is he? 56. So most likely, if you can, you'll be able to get this lens out before you'll need the capsular tension ring. I always like to get as much of the lens out before I place the capsular tension ring, because it makes it harder to remove the cortex, the remaining cortex and nucleus. And depending on if this is it looks like a 3 clock hour, you might get away with a capsular tension ring or two. You can side by side them and make sure you have a stable capsular bag, or you could put a segment in there and suture it.
Great. Yeah, those are all, you thought very much similar to how I thought. So I actually did use Zepto in this case. And so I decided to use iris hooks to expose that area of interest because I wasn't quite sure if the ring would allow me to see quite that far out. And the nice thing about Zepto is you don't actually have to use trypan to visualize the capsule, since you can applanate right against the lens and allow it to do the work for you. And so here you could see me inserting the device into the eye. And once I'm in the eye, I'm going to withdraw the rod again and allow that silicone cup to expand. And the other reason I like to do this is, you were mentioning doing the manual CCC, not having to put any stress on the zonules during that manipulation there. And instead of centering it on the Purkinje light image this time, I'm going to center it right on that center of that petaloid cataract, because that's where I know the center of the bag is. That's where we're going to pull it over to center the lens eventually. So suction against the capsule as usual there, centered on the petaloid cataract. Deliver the energy and then release the suction with that reflex, as you can see here. And then after every time I do this, I like to check that capsulotomy tissue, make sure it's nice and circular, no tags. And once I've achieved that, just like you mentioned, put in capsular tension hooks as I do the removal of the cataract itself. Zepto lends itself well to this because I believe it was Vance Thompson on the celebrity panel who showed the strength of the capsulotomy was about 4 times stronger than a manual CCC. And that matters when you're using things that are putting tension on that anterior capsule, like hooks or this Ahmed segment, right? This is going to put tension on that anterior capsule for the rest of this person's life. And so I really want to make sure that I'm not, during manipulation and afterwards, going to have to worry about any sort of rent that's formed. This is day 1, beautifully centered lens. You could see the capsulotomy edge there. No problems, no pseudophacodenesis. This patient was very happy. 2070 on day 1, 2025 uncorrected at week 1. And this case, again, was could have been very difficult, made a lot easier with Zepto. So if anybody wants to investigate further, we actually just published a paper this July. It's online ahead of print for routine cases and complex cases. It's just a fun paper talking about different cases that we've done for surgeons around the world. Out of 340 surgeries, 99.4% free-floating capsulotomy, and then a review of 52 cases showed a mean diameter of 5 millimeters, 98 cases with the 360-degree overlap of the IOL, and really good symmetry with only an ovality of 3% there. So switching gears here to our final case, 66-year-old female with a dense cataract, as we talked about before. Patient concerned about long post-op course, really was hesitant when we were talking about possible need for further surgery. Doesn't really like the idea of a lot of corneal edema. Nobody really does. On presentation, hand motion vision, history of distant ocular trauma, but no phacodenesis. And it's just very deep brunescent cataract, absolutely no red reflex, and the B scan was normal. So I'm going to pitch this question to Dr. Vance Thompson. How would you manage this super dense cataract?
Well, the first thing I would ask is I would be looking at my biometry and seeing what my anterior chamber depth is, because I know that I need a beautiful capsulotomy to start this. And if it's less than around 3.6 millimeters, if it's greater than 3.6 millimeters, I start to worry about getting the applanation that I want. And different people have different numbers of how deep of anterior chamber depths, but I don't think you want to be going beyond your comfort level in a case like this. So if the anterior chamber depth, which it typically is in a case like this, less than 3.6, I would use the Zepto device for my capsulotomy. And I would be doing very gentle hydrodissection. I would be going to the dense settings of my, phaco emulsifier, and I would be protecting that endothelium. And I would just go slow and low and work through it. But I would do the capsulotomy with Zepto if it wasn't too deep of an anterior chamber depth.
Great. Yeah, this was done with Zepto. What I'm going to present next is actually a new technique for phaco. We're going to switch gears here to a new technique. And it's a technique I've coined rotary chop, and that's because it resembles the rotary dial on a phone. And I created this because even though during my fellowship abroad, I was able to be trained in manual small incision cataract surgery, sutureless extra cap. For the phaco-only surgeon, I really wanted to develop something that's really safe and wouldn't use a lot of CDE for these dense cataracts. And so if you remember this picture of the phone, I'll show you why it's called that. So back to our dense cataract here. I start by using my normal chop settings and just basically drilling a hole into the dense cataract. And I don't continue as I normally would with my vertical chop. I end up spinning the lens 180 degrees around so that that initial hole is away from me. And then again, I burrow down into that cataract and I use that initial hole I made to place my chopper super deep into that dense nucleus, deep enough where I can create this large crack. And you can see just how dense that lens is in slow motion there. And by using that extra hole that I made, I don't have to put any stress on the zonules and I can still get my chopper really deep into the lens. And so at the end of the case, you could see this was a Zepto capsulotomy and you could see perfect centration there on the Purkinje light image. Even though the CD was 23, which is higher for most chop surgeons, by no means, I don't think this patient would have, been in that danger zone for their cornea. They ended up doing great. And it was because I was able to really segment that lens nicely with that initial rotary chop. For trainees, it's great for teaching chop. And then also if you're not familiar with chop and you're just out in practice, this is a great stepping stone to vertical or horizontal chop. This is one of my residents, Erin Seek, from last year. She's a great surgeon to begin with, but this is her first attempt at it. So she makes that initial pilot hole and you could see me asking her to spin the lens around. She burrows into that again. This is her first attempt doing this, putting the chopper in there, bringing the two instruments together and then apart. And so it's really great for teaching people chop as well, because it keeps them away from that horizontal chop where they're not comfortable working in the periphery. And then also for vertical chop where you seem to break occlusion a lot when you're first learning chop by pushing that piece off of the phaco tip. And so I found it really easy to teach people all around the world this technique. And so lastly, group question here. Any comments and I should mention you can make you could pre-drill holes into it more than just that one to make those subsequent chops a lot easier. So any comments on this technique, any ways of improving it? Do you think you would incorporate it into your practice?
I think that was pretty beautiful, Christos. I hadn't seen that. I've sort of done something like that, but not prepared like that. So I think that's a beautiful way to show. Another tip for the audience, loop is a device you can slide that. With that beautiful capsulotomy, you can now slide a MyLoop in and you can bisect that lens and have 6 pieces very easily. Just keep pulling it back and it rotates automatically. Toby Tyson did this little thing where he just doesn't even have to rotate the lens. You just pull it back and then expand it again and keep pulling it 3 times and you have 6 segments. So any of those are great. I had never seen yours. It's a beautiful technique.
Thank you. And yes, the MyLoop is a great instrument too.
Yeah, it's always frustrating to me when I see new things and I think to myself, why didn't I think of that? That's so brilliant. We should switch places here. Can you be the panelist and I'll swap with you, because that's a really fantastic technique. I sort of learned chop. I backed into chop by doing femto. And the nice thing about femto was, it makes I can do a 4-quadrant divide and conquer with Catalyst, for example. And it allowed me to really figure out, how deep I can put my chopper, and it sort of, guided me. So I kind of learned how to chop by doing femto, believe it or not. But I think this is fantastic. I mean, what I've learned now that I've chopped for thousands of cases, I've learned that in really dense lenses, you want to drill in, and instead of pushing the chopper down, you're really pulling the lens up. And so you're not really putting stress downward as much as you are pulling the lens upward to meet that chopper. So in really dense lenses, it's kind of a reverse function. In softer lenses, you can kind of do a, more of a traditional downward motion. But with these, you want to almost pull the lens up to meet the chopper. That way you're not stressing the bag.
Great point.
But this is a great technique because it obviates that whole awkward maneuvering. And if you don't know what the feel is yet, this makes it just perfect. So great job.
Yeah, I agree. A beautiful technique.
Beautiful.
Thank you.
Another thing you were mentioning also about with femto and learning it, imaging is you get so much information when you have imaging. I have been so surprised so often at how thin a lens might be. And
Yes.
you think, so some are really fat or thick and some are really thin. And by seeing the image in advance on the femto, you take 2 sculpts and you're going to be through the capsular bag. So it's something always it's more information in surgery to really guide you. So there's all these techniques that we have today to really make us safer surgeons.
Yeah.
Hey,
Well,
Chris,
thank you, guys.
before we move on, there's a question from the audience, and the
Sure.
question is, if the suction is not complete is not enough, let's say on the Zepto, does it
Mhm.
mean that the capsulotomy, and anybody, panelists can answer this, but does it mean that the capsulotomy would be incomplete, or would it not just happen at all? I mean, what happens if the suction is not enough?
Yeah. So if the suction's not enough, in the cases that I've experienced, nothing will happen. So let's say I've used cohesive viscoelastic foolishly, even when they told me not to use it, because I did want to pressurize that, as much as I could. I thought, great, I've got occlusion there. It looks great. It just basically fires into the viscoelastic and doesn't do anything. I guess theoretically, and the other panelists can chime in on this, but theoretically it might be able to, but I really think it's generally quite safe.
Okay.
One of the things that you want to be careful of is in the neck or the throat leading to the suction cup, you saw the push rod that's used to extend the nitinol ring as you go through the incision.
Right.
And one of the mistakes an early user can perform is as you withdraw that push rod, you don't remove it fully from the throat. And so the panel that your assistant is running is showing that you've achieved beautiful suction, but you haven't. You're getting proper suction on your panel, but on the silicone cup, you're not, because the throat is occluded. And this is probably one of the riskiest times with Zepto technology. And we try to teach anybody that's doing it to fully withdraw that push rod, because if you don't get full suction, this is when you can get typically a complete cut, but not get the same temperature elevation that leads to the strong edge. And so it's oftentimes a weaker edge then, and you can get an anterior capsular extension. So not withdrawing the push rod fully is a mistake you want to prevent.
Well, thanks, Vance. That's very, very helpful. Small tips, but they go a long way when you're actually doing the procedure. And I think I know where you're getting at with that. So thank you so much. Christos, back to you.
Yeah, just to summarize, thanks, Vance. This is just if you want to learn more about rotary chop. It's there's a paper that we published in April, just shows more videos and describes it in more detail. The only other things I'd like to, say it's helpful for small pupils, especially if it's a dense lens. You don't, if you're a horizontal chopper, you don't have to go out in the periphery in areas where you can't see. And then zonulopathy, if you really want to make sure that you're not putting a lot of stress on the zonules. I know Gary mentioned his technique where you can lift up on the cataract, which is the ideal way to do it. And so this can also help mitigate any sort of stress on the zonules. But that's it.
Perfect. Any further questions? Yeah. Christos, thank you so much. First of all, I think that presentation was just absolutely phenomenal from a new technique standpoint and bringing forward what's really new in cataract surgery. So thank you so much first.
Oh, thank you so much.
And
really
panelists and our celebrity panelists, thank you so much for those really, really fine points you guys gave, which make a huge difference to the young surgeons and the young Turks all around the world. Yes,
Can
Sam.
I add just one point?
Please, absolutely.
Christoph, I thought that was an amazing presentation of especially challenging cases. Being a refractive surgeon, I have a tendency to refer those cases to my partners, but I love to talk about them, and I deal with them too. But my point is, it's a wonderful technology for refractive cataract surgery. And you talked about how you like to center on the first Purkinje image. And I just loved that, because one of the things that I'm really trying to create, like you said, was 360 degrees of capsular overlap. And so for long-term happy patients, we don't just center the optic of our premium implant, we center the capsulotomy with the optic so that we get that beautiful overlap. So we don't have part of our optic not overlapped, which with capsular contraction can lead to tilt and decentration. So I was so happy you mentioned that. I just want, for the audience's sake, you talked about some beautifully tough cases, but the same techniques you taught are so wonderful for refractive cataract surgery.
Yeah, I'll just go ahead. I'll say something else also. Christos, the cases that you presented, require a lot of courage. And I just want to say to all the young surgeons that are out there, when you sit down and you're scrubbed in and you have that patient's eye that is now your responsibility, it's okay to take a deep breath and realize, you have a lot of brothers and sisters in arms around the world who are sitting there, even if we're not sitting there next to you physically, we're there with you in spirit. And so it's always okay if you have a tough case to reach out to a friend or a mentor to say, hey, can you look at a video for me? Can you help me figure out what I did wrong? Christos showed beautifully, both how you can panic in a situation of being uncertain when a white cataract disappears, and you have to keep your wits about you. And you have to work the problem and not get panicked. And, he showed also how a loose zonule case can be something that it goes from being absolute nightmare to a beautiful result just by working the cataract slowly and methodically and being very thoughtful about each step. And then showing, a new approach to vertical chopping, which again is something that can be very anxiety invoking for new surgeons or even experienced surgeons who haven't figured it out or haven't had someone to sit with them. So I think it's important as we talk about, rising stars around the world, that that there is a community of ophthalmologists at various stages who would just love to help it's a rising tide that floats all boats. And we would love to, continue to help each other become better surgeons and learn from each other. So thank you so much, Christos, for these beautiful cases and showing us how it's done.
Thanks, Gary, for saying that. Yeah, I think that goes a long way for us to know that everybody struggles with a lot of these cases, and we're not alone. So I appreciate you saying that.
And I will add that the struggle doesn't end. And because I moved out to California and I said, wait a minute, where are these California cataracts? I thought, they're not. I mean, I think they followed me from Baltimore, and I had the most complex cases there, and I get them here too. You will get them all your life. So what you've done is, what we all do together is share all these new technologies, show when to use them, be comfortable, have them in your OR. So one of the things I said, and I said it to you when I was mentoring you in the class, I said, when we were doing our surgical training at Bausch, and I said, you are king or queen of your OR. And you have to remember that. Don't go in there unprepared. Find out what tools you want. If you want iris hooks, fine. If you want Malyugin, find what you're most comfortable with, and ensure that when you get in those types of situations, that you can handle them because you have the instruments that you need. And that's what you showed us. You can pull out so many things in one case, and don't be afraid to do it to save that person's eye and give them a beautiful outcome like you did. So thank you for sharing all that with us.
Christos, just before we close, I think there are a couple of questions, or anybody from the panel. Which chopper was that? If you could just tell us which chopper that was. That is a question that has come in from an audience. Can you
yeah, it's the Nickman 2 Quick Chop. And shout out to Dr. Mark Bleacher at Wills. He was the one who taught me how to use that, and that's the one that I use now. So, yeah, it's like you can get it from Catena and a couple of other places too.
Fantastic. Another question. Do you center the capsulotomy on the first Purkinje image or center it on the bag? I mean, the visual axis center to the limbus. So from the Zepto perspective.
Vance can probably answer this better, but it should be the same thing. I mean, the visual axis, when you're asking the patient to look at the light. So, it is difficult if they have really dense cataracts, let's say. But in general, if they have good clarity and can see, the different lights, you'll ask them to look at it, and then you center it as they're looking at the light.
So I think where the person is from, I think the question comes when you are giving a peribulbar block, and most of these cases are tougher cataracts for them. And when they give a block, they're not able to look or particularly point yourself in a direction. Vance, can you give us some tips on that?
One of the beautiful indicators that we have in surgery are obviously the Purkinje images, and we know that there's 4 of them, but I find that it's the first and the fourth that really help me the most. And the first is upright, and the fourth is inverted. And when you have people that aren't so sleepy under topical anesthesia, look at your microscope light, you will start to learn the relationship of the first and fourth of your scope when they're fixating. And so if you have someone who's got a little bit more anesthesia, or you've done a block, if you line up the first and the fourth and center on that, you're going to be very close to their visual axis.
That's where you want to be. Thank you so much. And we come to a close of the inaugural episode of season 1, Rising Stars in Ophthalmology. As we come close, I want to tell our audience, please do register and tell as many people as you can to register, because the registration really helps us keep aligned with your needs of getting in touch with you, sending you only a reminder, not spamming. I know how that feels, so we won't do that. But very important, I wanted to thank each and every celebrity panel first over here. Vance, thank you so much. Namaste is the new hello, so I'm going to namaste everybody.
Thank you. Tell him hello
Gary,
too.
thank you so much. And Sherry, your words of wisdom are always delightful. So thank you, all of you, for being here tonight. Christos, special thank you to you for presenting a beautiful series of cases, as well as talking to us on a new technology in cataract.
Well, thank you all for the generous invitation, and it's been an honor. I mean, you all are heroes of mine, so I'm flattered to be able to be a part of it.
Before we sign out, I have to thank Jen Lowe as well as Bill Trattler for this fantastic series and who've helped put this all together. I also wanted to give an update for the next episode. It is going to be on September 15th. The episode 2 is on September 15th. Let me tell you, the same time follows. We don't change any of the timings from global perspective. We'll also have the video on demand on our website within less than 24 hours. So people who have missed this show can obviously watch it online, and would like you guys to post it as much as you can to get the word out there. We don't use any marketing of any sort. Anyways, thank you so much, guys, for being a part of this inaugural episode of Season 1 Rising Stars in Ophthalmology.
Thank you.
Thank
you.
you.
Thanks.
Bye. Thank you.